Let's talk about the eyeball, ocular ultrasonography. Um, if you think about it, it's almost like the eyeball was created for being ultrasounded. Because if you kind of look at the structure, right, it's superficial, it's right at the surface, and it's fluid filled, which makes it really amenable to imaging using ultrasound. And the use of ocular ultrasonography has been in practice in acute care since probably around the early 2000s. And there's really two sort of contextual applications where ocular ultrasonography is used most often. First is in acute care slash emergency care slash trauma care, where you're trying to use ultrasonography to identify globe injury, things like globe rupture, lens dislocation, foreign bodies, that type of thing. And also non-traumatic things like retinal detachment and vitreous hemorrhage and other intraocular, specifically posterior chamber pathologies, which are really easily identifiable using ultrasound. The second category is in the setting of critical care, where we use optic nerve sheath diameter as a screening technique for intracranial hypertension. We're going to talk really briefly about the acute care stuff, but the focus of this talk, because we are critical care folks, is the use of ocular ultrasonography to screen for increased ICP. So let's start with the probe choice. You can use any linear probe as opposed to DVT ultrasonography, where we choose, if we have a choice, we choose the large or the wide footprint linear probe because it gives you better depth. For ocular ultrasound, you should choose if you have the choice, the smaller footprint or the narrow footprint probe, because this gives you better overall resolution, though with a not as quite a deep field of view. But since the eyeball is very superficial, you don't really need that depth. So if you have the choice, grab that narrow footprint linear probe. But this one will work as well in a pinch. There's two, I guess, ways of approaching ocular ultrasonography. And you can think of them sort of with respect to the axis of the optic nerve and how you visualize the eyeball. The conventional approach is looking at the eyeball such that you're looking at the long axis of the optic nerve. And we'll talk about that first. There are a couple newer approaches which are gaining traction and gaining evidence where you actually look at the eyeball such that you are looking at it in the transverse axis of the optic nerve. And these differences really become more pertinent when you're looking at the optic nerve sheath diameter, but we'll talk about both of them. If you're looking for sort of an ocular, sort of survey, typically the long axis view of the optic nerve through a transverse axis of the eyeball itself is usually the preferred approach. So here's that approach. So this is a nerve long axis approach or a transverse to the eyeball approach. So what you do is you will place the probe on a closed eyelid with copious amounts of gel. Ideally use sterile gel, so don't use the gel you used on the bladder ultrasound just previously. Use the little packets of gel and put the gel directly on top of a closed eyelid. And put the transducer, clean transducer, directly on top of the gel. Really, really light pressure. And what you want to do is your transverse axis, the dot's going to point to the patient's right. You want to, unlike what's shown in this image here, you really want to make sure you're anchoring your hand so you're not pressing down too hard on the eyeball. Because even the smallest amount of pressure can dent the eyeball and exert external pressure into the globe itself. And if you're dealing with someone who may have increased intraocular pressure or globe injury, you do not want to put too much pressure on the eyeball. So you want to anchor your hand in one way or the other. Either you can take your last three fingers and sort of put them on the zygoma, almost like you would when you're anchoring a needle when you're putting in a central line after you've entered the vein. Or you can sort of stand on the other side of the patient, almost as if you're intubating the patient, and then just put your hypotenuse eminence on the patient's forehead and put the probe on the eyeball. Either way, really, really light pressure on the eyeball is what you're going for. So when we're looking at the eyeball in transverse axis, this is the relevant anatomy. These are things that we're going to see with a fairly high degree of fidelity. Here is the lens here, the iris and the ciliary muscles. So this would be the anterior chamber here with the aqueous humor. The space in between the iris would be the pupil, of course. Posterior to that is the posterior chamber with the vitreous humor. Lining the back of the eye is the retina. And then going through to the posterior side into the cranium would be the optic nerve, surrounded by the optic nerve sheath. Sometimes you can pick up the optic disc as well on ultrasound, but these structures here are actually very clearly visible using ultrasound, and here's what that looks like in transverse axis. So you can see anterior chamber, there is the cornea, there's your lens, your iris, and your ciliary muscles, posterior chamber with the vitreous, and then here is the optic nerve sheath with the optic nerve inside. Okay, so again, fluid-filled ball. It's supposed to be largely anechoic, and the few structures in there are very clearly demarcated. So as you can see, it'd be very easy to pick up any small abnormality within this anechoic ball here. So that's why ocular ultrasound is really helpful in picking up problems with the inside the globe itself. So here's what a globe rupture looks like. So this normally anechoic space here in the posterior chamber is replaced by blood and clot. You can see that there's sort of a track of injury going from anterior to posterior chamber. There's some more, blood and clot here. So that normal anechoic ball is disrupted, and the normal anatomic structures here are disrupted as well. Very easy to pick up. This is the result of blunt trauma. You can see up here there's some, edema there, and then a fair amount of soft tissue in between. So this is an eyeball that was essentially swollen shut, and the ability to get a good eye exam was not that great here. And again, what you don't want to do is try and pry open the eyeball to get a look at it. So what you can do is just put an ultrasound probe on very lightly, and you can get a really good look at stuff that's going on posteriorly. Here is an example of penetrating globe trauma. This is a piece of shrapnel. This is in a soldier who encountered an IED during dismounted patrol. So he was on foot and the IED exploded. And it looks like the shrapnel was blown probably underneath his eye protection and got into his eyeball. So there's the piece of shrapnel there, very easily identifiable. And you can see here, the normally anechoic ball is replaced with hyperechoic blood and clot. You can see a little bit up here as well. This is lens dislocation. This is someone who was swatted in the eye. You can see that the lens is not where it should be. It is knocked backward. The iris is torn here. You can see that. And again, that normally anechoic posterior chamber is replaced almost entirely with blood and clot. So this is a dislocated lens. And here's an example of retinal detachment. So the eyeball itself is fairly anechoic, but you can see this linear looking hyperechoic structure sort of floating in the vitreous here. And this is the retina, which should actually be pasted here. So this is a retinal detachment. I don't know how many of you are at all good at doing, dilated exams using an ophthalmoscope. I'm not. So me diagnosing this by looking in the eyeball probably would be a no-go. But it's again very easily identifiable just using ultrasound. So as you can see, looking for even small, even subtle anatomic abnormalities in the eyeball is actually really easily approachable using ultrasound. Okay, so that's ultrasound in general, sort of acute emergency care. Now let's talk about the use of ocular ultrasound for critical care, and specifically we look at what's called the optic nerve sheath diameter, and that is used as a screening technique for increased intracranial pressure. So the principle behind that is that the optic nerve itself is surrounded by a sheath, and within that sheath, sort of bathing the optic nerve, is the same CSF space that's contiguous with the intracranial CSF spaces. And so if you have any sort of pressure in the brain, around the brain, it's going to create a back pressure on the CSF spaces and cause the CSF spaces, at least extracranially, to dilate. So what you will see is, as the pressure in the cranium goes up, the optic nerve sheath, as a result of back pressure, is going to dilate. Okay, and we can actually measure the diameter of the optic nerve sheath to correlate it with intracranial hypertension or high ICP. And so, like I said, there's two approaches you can use for this. The first approach, again, is the transverse axis to the eyeball, which gives you a long axis cut through the optic nerve sheath. And what you do, like was pictured in that first image there, transverse approach, you want to go sort of high in the orbit, and you're going to visualize, you're going to increase your depth to visualize the optic nerve sheath, and just angle very subtly anteriorly and posteriorly to make sure you're getting the widest diameter of the optic nerve sheath possible. Okay, you're going to freeze it. You're going to measure posteriorly from the vitreous into the optic nerve sheath about 3 millimeters, and you're going to measure the diameter at that level. So here's what that looks like. Here's the eyeball here. There's the optic nerve sheath. You can see that the depth has been increased. Okay, that's the optic nerve. You can sort of see in here. And then around it is the optic nerve sheath, the white dotted lines. Okay, so this whole part is the fluid-filled optic nerve sheath. And so you measure down 3 millimeters, and then you measure the diameter at that level. And here it's a little bit dilated, 0.53. Okay, there is a somewhat wide range of normative values. So this is in a relatively heterogeneous type of population when it comes to gender, age, in adults at least, and so on. There have been a couple studies looking at different ethnicities as well. But in these studies, the range of normative values for optic nerve sheath diameter went from anywhere from 3.8 to up to 5.1, with a mean optic nerve sheath diameter of around 4 millimeters. The highest normal value recorded in any of these studies was 5.2. So that's where that magic number of 5 millimeters comes from. If your optic nerve sheath is dilated more than 5 millimeters and you have clinical concern for high ICP, then this is sort of a positive screening test for intracranial hypertension. Okay. There have been some postulated limitations to this number, using a single number for everybody. Again, is there some difference when it comes to gender? Are there some differences when it comes to ethnicity, height, that kind of body surface area, that kind of thing? It's sort of unclear. There is clearly some range in normal values, but is this range actually bigger than this? I don't think we know 100%. So there are a couple of studies which have looked at what's called your ratio to the optic nerve sheath diameter to the external transverse diameter of the eyeball. So basically what you do is you sort of ratio the optic nerve sheath diameter to the external transverse diameter. And I believe the ratio is somewhere like 0.4, if it's greater than 0.4 to 1, optic nerve sheath diameter to external transverse diameter of the eyeball, then you are concerned about intracranial hypertension. This measurement, this set of data and its validation is still in its infancy, so I wouldn't use this yet or quote this yet, but this may be something that is emerging when it comes to maybe trying to get a little bit more precise on what actually correlates with optic nerve sheath dilation. Okay. There are some limitations, which I'll talk about, to measuring a tubular structure in its long axis. Anyone who has a background in ultrasound, we're always taught that if you're measuring something that's a tubular in shape, you should always measure it in its transverse axis, because that way you know what the true diameter is. Okay, if you're trying to cut something through its long axis, a tube shape through its long axis, you can never really be 100% sure you're cutting right down the center, and then the diameter you're measuring is the actual diameter. Okay, so there's some increasing sort of a tendency now to try and measure the optic nerve sheath in its transverse plane. And there's two approaches you can use for this. Okay, one approach is this one, where you actually put the probe in the long axis and you approach the eyeball at around the lateral canthus, and you point the probe upward. The other approach is going all the way inferior in the orbit, in the socket there, and actually angling superiorly in the transverse axis. Okay, an indicator the patient's right. The goal of both of these views is to actually get a transverse view of the optic nerve and optic nerve sheath here. So instead of looking at the optic nerve and sheath in its long axis, you're looking at it in its transverse axis. So you're looking for a round shape. So if you look at what we're imaging here, that is the optic nerve itself. sort of a circular shape, and that thing around it is the optic nerve sheath. Okay, optic nerve sheath. So because you're looking at it its transverse axis in its round shape, you can be sure that this is the actual diameter that you're measuring. Okay, so that's the idea behind that. Okay. The other theoretic downside of using the transverse eyeball long axis optic nerve sheath measurement approach is that when you image the optic nerve sheath that way, you're actually going through the lens. And if you have someone who has an abnormal lens because of cataracts, for example, it could potentially cause diffraction or scattering of the sound waves in much the same way cataracts cause scattering and diffraction of light waves. And so that could actually create artifacts posterior to the lens and distort the stuff behind it to include the optic nerve and optic nerve sheath. So theoretically, you could have some error in your measurement if you're trying to look through an abnormal lens. Okay, so this is why trying to use some of these other approaches may be better. The downside, of course, is some of these approaches, especially the lateral canthal approach, is more difficult. And they're not as widely validated. There's only a few studies, descriptive studies largely looking at this. So I wouldn't say it's ready for prime time yet, but it's gaining steam. And maybe in the next few years, it will supplant the transverse eyeball long axis optic nerve sheath approach. So definitely learn how to do it both ways. Okay, so back to the clinical application. What is the purpose of measuring optic nerve sheath diameter? Again, think of it as a screening test for intracranial hypertension. Okay, your goal is to identify evidence of high ICP early. Okay, so this, like any other screening test, has its highest yield in those patients who have a high pretest probability for, in this case, intracranial hypertension. So this is a patient who has clinical syndrome that makes you concerned for high ICP. They had head trauma, for example, they're altered, they're vomiting, or they have a acute change in mental status, acute change in neurologic exam, pupillary abnormalities, a clinical syndrome that is making you concerned for high ICP, so their clinical pretest probability is high. If in that patient you measure the optic nerve sheath and it's dilated, then that's very concerning for high ICP. Okay. And a dilated optic nerve sheath in someone who is totally normal and intact neurologically, don't really know what the significance of that is. Okay. So practically what this allows you to do, it allows you to initiate presumptive management of high ICP long before you've gotten any sort of imaging, long before any sort of specialist has arrived to do invasive measurements of ICP. So you can do things like intubation, hyperventilation, osmotherapy, positional optimization, all while you're on the phone with neurosurgery and all while you're spinning up your imaging, your CAT scanner or what have you to get a more definitive diagnosis. Okay. There have been several cases, even in the medical IC, where we've identified evidence of high ICP and have been able to start management early, saving several minutes to even an hour or two. And of course, time is brain in this context. Okay. Similarly, if you're in an austere setting, you can use this, particularly in the trauma setting, to help you decide whether you need to evacuate the patient to a higher level of care or a hospital that has a specialist like neurosurgical capability. Okay. So high pretest probability screening test helps you intervene early. Okay. If you have questions, again, come and find me, shoot me an email. Otherwise, I look forward to scanning with you.